All right. I'm seeing folks trickle in. Welcome, everyone. We're going to go ahead and get started in just a moment. So go ahead and get settled in. Thank you for joining us. Welcome to everyone who's joining us. As you get settled in, would love to hear from you. Hop into the chat and introduce yourselves. Let us know where you're joining from. Super excited to get this session started today. Great. I'm going to go ahead and get us started. Just in the interest of time, welcome everyone. My name is Danya Madhusudan. I support our people and community folks through our portfolio experience team here at Insight Partners. Today, we're going to have a conversation on health equity as a part of our Black History Month programming. And before we begin, I have a few housekeeping items to go over. This session is being recorded, so if you would like to share this recording with someone afterwards, we'll be sharing the link with you by the end of the week, and it will also be posted on our website and Insight Go for those of you who are in our portfolio. We've sourced these discussion questions from all of you during the questions that were submitted during registration, so we're really excited to address what's top of mind for folks. We do have a chat function, so we encourage you to interact with one another and introduce yourselves in there. If we do have time, we're going to incorporate a few additional questions from the audience at the very end. And then the last thing for housekeeping is that we have a 30-second survey that will pop up on your screen. And so please take a moment to let us know how this event went. We really do read all of your feedback and incorporate your suggestions into future events. And we're really grateful to be able to host these types of webinars to engage our larger community and address these topics head on in a space that's supportive and an environment like this one. And so for those of you who are in our portfolio, we do invite you to join our CEO Scale Up Pledge community if you haven't done so already. So I'll be popping information into the chat right after this. We have an opportunity for your company to gain access to a bespoke community of committed people leaders or culture bearers who are leading organizations and building them with a lens of equity and inclusion. And so we send out monthly newsletters to keep you updated on our curated partner programming and our monthly digital events that really leverage peer-to-peer learning and the larger network of companies that are in our portfolio. We also have training programs that support early career employees and connect them with those in similar roles across our companies as well. And so that's what our Level Up to Scale Up programming is and Manager Essentials programming. So if you'd like to learn more, please reach out. Our team is really happy to work with your organization. And with that, I will be passing it over to Isabella to introduce herself as well as the panelists today.
Thank you, Danya. Pleasure to meet everyone. For those that don't know me, my name is Isabella. I've been at Insight for more than 6 years now, originally from Costa Rica, and very excited to host this panel today. To just dive into introductions, we have Dr. Garth Walker joining us today. He's the Chief Medical Officer at Rush Health, overseeing value-based care initiatives for more than 160,000 patients. He's also a board-certified emergency physician, recognized as a public health and health equity leader. Previously, Dr. Garth was the Deputy Director at the Illinois Department of Public Health and served as a White House Fellow at HHS. Then we have Mr. Chris Sastry. He's a managing director at Insight Partners, bringing over 30 years of experience in tech. Prior to joining Insight, Chris was the CEO of Abris, a data and software business serving healthcare, retail, and public safety. He currently sits on the boards of LK and Bamboo Health in healthcare and several other data and tech businesses. Prior to Abris, Chris held various senior roles across product, strategy, technology in both healthcare, financial services, e-commerce, and other infrastructure businesses. And last but definitely not least, Mr. Scott Barkley, Managing Director at Insight as well, leading our work in healthcare software. He has 25 years building and investing in healthcare companies that expand access to care with an aim of higher quality and lower costs. He's originally from Virginia, and fun fact, he actually studied under Julian Bond at UVA and wrote his thesis on questions of federalism in the 1960s civil rights era. With that, wanted to kind of flip over and just set a little bit the stage here. I want to emphasize that health equity is more than just a moral imperative. It is an economic and innovation opportunity. Disparities in healthcare costs, access, treatment, and outcomes create inefficiencies, keep driving up costs, and also leave millions without adequate care. Just to share a couple of stats here. 20% of Americans live in primary care shortage areas that limits their ability to timely care. Then 54% of rural communities lack obstetric services that worsens material health disparities. 36% of Americans have low health literacy that makes it really hard for them to navigate the healthcare system. And 70% of Black adults report unfair treatment in healthcare due to race or ethnicity. However, there's various market forces that are driving change, and this provides a positive outlook moving forward. One, we believe that digital health acceleration will make a material impact in this space, as virtual care and AI-driven diagnostics are expanding access. Second, value-based care. So we've seen a 16% increase in adoption since 2016, which signals a shift towards patient-centered models. Third, it's the adoption of precision medicine and data-driven healthcare. Worth noting that even though personalization is key, equitable implementation remains a challenge. And fourth, social determinants of health that emphasizes that addressing housing, transportation, and nutrition is critical to improving outcomes and lowering costs. With that, maybe we can shift a little bit and just start hear the discussion today and get to the meat of it. I wanted to start with a pretty kind of like high-level question to all the panelists. Given that health equity just means so many different things to different people, how would each one of you define health equity from your perspective?
Thanks, Isabel. I can take the first crack at that. I tend to think of it particularly in its most formal definition, but also what it has meant for me. I think in its most formal thought process, it's the ability for people to achieve optimal health, regardless of your socioeconomic status, regardless of your age, regardless of your sex, regardless of where you reside. But I would say that when I think about it in my career, I've served and worked in the academic setting, I worked in federal, I've worked in state, I've worked in the private sector, and the culmination has been most front of mind since COVID. And I think that was one of the biggest points where we were able to observe the culmination of neglect when you don't consider health equity in terms of how we think about what our patients experience on a day-to-day basis. I remember at the front end of COVID, working in the emergency department before I joined the State Department of Public Health, how 70% of the deaths occurred in Black and Brown communities. And when we think about research, we have all the research. We have long-term research, we have RCTs, we have very high quality research. We knew where the disparities exist. But at the same time, there was still a gap and a threat that occurred amongst our most marginalized communities. And so I tend to think about how we think about people's lived experiences and how they're able to engage our healthcare system, how they're able to engage tech, how we're able to innovate around it to be able to lessen that access and make sure that when people experience our healthcare system, they feel the empathy that's built into it. And how do you build empathy and how do you build trust? You ensure that access is equitable and people have that opportunity to achieve optimal health. So by being able to consider the social and economic barriers that different communities experience in terms of getting good healthcare, is one of the keys to be able to address health equity.
Scott, I'll go next. Bella, I like CDC's definition, which I think is pretty succinct, yet all-encompassing in its scope and purpose. The way CDC defines health equity is it is the state in which everyone has a fair and just opportunity to attain their highest level of health. And so if I unpack CDC's definition, I really find three key words there that are worth hanging on to, which is one is everyone. And it is not just about headcount of number of patients, members, eligibles, covered lives, or whatever other term we use to identify a person. It is about the being able to identify everyone by their unique attributes and circumstances and factor it into every stage of the healthcare process, all the way from diagnosis through to patient activation, through to intervention and ongoing support. The second is probably not a word, but a phrase, fair and just, right? And this can get tricky really fast, but as I think about it as a product guy, I just see enormous opportunities to leverage technology to bridge the gaps that would previously have been hard, if not impossible to bridge, that too at scale. And the third is attain, right? Which is the attainment of the highest level of health. Often healthcare outcomes fall short, not because of lack of diagnostic capabilities. Candidly, it's not even because of lack of knowledge on exact care pathways to deliver outcomes. It is because of the chasm between knowing what needs to get done and how to get it done for that given patient, given who they are and their circumstances. And so there again, I see from a technology investor perspective, lots of opportunities to meaningfully impact health equity by bringing in principles of mass personalization in that critical nexus of physician-patient interaction.
I'm not going to add too much because I think both definitions were pretty great. I'll start by just thanking Danya and the Portfolio Experience team. Thank you for bringing this together, for bringing a lot of our portfolio companies and employees here. And second, Dr. Garth Walker, just thank you for joining us this morning. Like, it's wonderful to see you. People should know Garth is a friend to the firm. We talk about these days as we seek out companies that can make a difference, as we are trying to be closer to the front lines on certain problems. And so just taking the time, we really appreciate you. To the question of a definition of health equity, the past two definitions were so strong. I'll be very brief. I'll just use kind of a core word. For me, it comes back to dignity, kind of who are we as a society of how we take care of each other? And why do we not live in a society that is appropriately capitalistic, yet understands the dignity of the availability of care, regardless of with the zip code in which you were born or the socioeconomic status you find yourself in at that moment. So health equity for me is about the dignity of availability of quality.
And Krish, going back to you, maybe you've noted the importance of introducing principles of mass personalization. So I'm thinking here with advances in data interoperability and AI, just what everyone talks about these days, right? What changes should we expect in how care is personalized at scale?
You see, very early in my career in healthcare, I had the good fortune of working with an amazing colleague, Ms. Michelle Hallman, who was teaching an engineer, about patient experience and patient activation. And to this day, what she said sticks out in my head. And I broadly paraphrase what she said. She said, Krish, remember, healthcare is the one place where perfectly capable individuals become dazed and confused. And that sort of stuck in my head, right? And a lot of that has to do with the physician-patient interaction, where physicians are often taught to tell you what to do, but not necessarily how to make it happen, with all due respect to Dr. Walker, right? I mean, the interaction oftentimes is more around take these pills, watch what you eat, exercise right. Okay, but what does that all mean, right? Which is, how do I actually make it happen? If I knew how to do it, I would have already done it. And how do I do so with the various factors that may get in the way? What are my barriers to activation and adoption? And so what is this so-called care plan, which is specifically for me? And when I think about it from the flip side, physicians are operating under extraordinary amount of stress and time pressure. And they, first of all, don't have all of the information they need, and they don't have the ability to then structure their interaction in a way that engages the patient. Yes, the patient may be a diabetic with some comorbidities, but it's a unique individual. It's a patient of one, right? And so I see significant advances in being able to put together a more cohesive picture of the patient, especially as interoperability mandates and supporting technology enable a more cohesive patient 360. I also see significant evolution in patient engagement technologies that are able to tailor the care plans or those interactions to specifically bridge the gap between the what and the how. The best of them embody not just clinical indicators, Bella, but other important factors for patient activation, such as lifestyle, social status, economic status, and other behavioral attributes, right? And there are cultural attributes to it as well, which is a better nutrition plan for a diabetic, uh, for a Caucasian may be different from an Asian, from an African American, and so on and so forth, given their cultural attributes. And so that's where the best of technology embodies all of those factors into it. And that combination infused with the right level of empathy, going back to the word dignity that Scott mentioned, for both sides of the interaction, right? Physician and patient, and the right level of usability, which is in workflow, the ability to be able to be multimodal in the interactions and adaptive, has the potential of delivering much better outcomes. And I think in the middle of all of this sits data and analytics as you try to morph that physician-patient interaction to better create activation and better sustenance of adherence to a care plan.
So I'd like to build off of that a little bit, because I think the phrase that I love the most that you just mentioned was the 360 view. I think healthcare inherently and will always be extremely local, no matter how many nationwide acquisitions that occur or expansions that occur. It always takes somebody to be able to understand the DNA of a community, the empathy of a community, and what are the challenges that that community is dealing with. And so anytime you have technology that can complement a physician and kind of remind the physicians of why they went into medicine, spend some more time with their patients and get to know all the things that are affecting their challenges, to be able to get good healthcare is an extreme win. I think one of the stories that I remember most when I was an early physician was when I was working at the VA, working with our veterans, and he came right before the holiday. And the issue was he had not been taking his medications regularly, and his labs were off to a level where I had to consider pushing for admission. And this patient was adamant about not being admitted before the holiday, of course, rightfully so. But when we think about why this patient was unable to take their medications, there was inconsistency in their job status, some other issues financially that may have disrupted their ability to be able to get their medication on a regular basis. And all of that was developed last minute, and we weren't able to be proactive to be able to address that solution. And in the broader context, conflict with this person's ability to be able to be with their family of four, be able to provide that time and be connected with their family. And I think it's some of those examples that build communities where tech can be able to integrate well and address physicians' ability to be able to have that connection with their patients, but also provide that 360 view for them to be able to be healthy and have the opportunity to be even healthier by being with their family the following day. And
I'm going to jump. I didn't mean to interrupt you, Doc. No, Dr. Walker, go ahead.
No, I was just saying it's the combination of those issues that make tech even more powerful and our jobs even more rewarding.
somewhat ripped from the headlines, because in the way we wanted to step through some of these questions, the next question was going to be to me around, building on Krish's questions around the role of software. But Garth just gave this amazing example, for example, on all the inefficiencies and kind of cultural barriers to people getting their medication properly. I can happen to say right now, at 3 different places within this firm, we are very deep on 3 different potential growth or buyout opportunities, where the core insight is software that understands all these middlemen oligopolists who make a lot of money making sure medications are very expensive, but with almost no regard to the broader societal impact. And on at least 2 of these 4 investments that we're looking at as a firm, they have software intelligence in this moment of intervention that greatly improves the probabilities of adherence and the probabilities of equitable distribution. And to be clear, they're like really good businesses.
Yeah.
Let me back up. If the question is kind of more broadly, why are we here today at Insight? Not only because we care about healthcare and we care about equity, but like, does software have a role? And Garth just gave us this example of his lived experience of this gap. And yet we're looking at shots on goal that are fundamentally capitalistic, but catalytic opportunities to solve a problem. So why is that problem there? Why are there at the heart of it, Commonwealth Fund says we're at about 17.9% of GDP in the United States towards healthcare. But if you look at all the things we drop, I'm pretty sure we're kind of north of 20%. And yet, if you look at our outcomes, we are materially below every Western and Northern European nation and most Southeast Asians in our outcomes. So let me get this right. We spend way more money to have worse outcomes. And then you won't be surprised in our slightly polarized, increasing inequality world, those outcomes are demonstrably worse as you get lower in socioeconomic and certain geographic areas. Does software have something to say about that? I will tell you, I think, I've heard it been said that software will eat the world. I think software can help heal the world. Software has a marginal cost near 0. Most of it have experienced in our personal lives. Sometimes when the technology works so well, we forget that it's there. It's like magic. That does not happen without software. Software makes things more intelligent. Software walks into places where there's a data complexity, but solves it in a way that's elegant for the user. I'll go so far as to say software, when done well, can bring delight. We have many portfolio companies and some that are like attending today with us, where that's actually like, I'm speaking to the core of what they're doing. They're solving a complexity. They're doing something delightful, but it's with an empathy to the end use case. And I'll go after one other statistics. Bella, you brought at the top around primary care. And even there, I think we've understated the problem. Primary care in this country is being hollowed out. Garth can give us significant evidence of the long-term quality of life and cost impact of good primary care. And yet the role within how economics in healthcare work, primary care is, there's almost no more independent, just fight for the family primary care physicians. Right now on Team Health, for example, we are actively asking, not, oh, how can we create another services business? That's not really Insight's business. But how can software power and infuse a future of primary care? What's the business model innovations that are going to bring us to that? What's the level of clinical intelligence and generative AI that start to create a better scaled solution where primary care can enable the right clinicians to lay on hands, while simultaneously in the back end, it's more intelligent, it's more empathetic, it extends into any community. And so I'm just kind of trying to connect the dots back for us as a firm that like software that powers these opportunities are a huge capitalistic opportunity. And I don't know how we get to a lower percentage of GDP and higher quality without software. Because the last time I checked, there's not a higher percentage of doctors coming through the pipe. Like, we have a moral outrage of what we put on providers. Our doctors are heroes. The question is, how do we build a system that augments them? And I don't know how we do it without software.
This is also great, and so many follow-up questions coming from here.
Great.
Dr. Walker, maybe to you, right? If we would take a step back, you as a provider and the CMO, what do you actually believe are the largest systemic barriers that are impacting patient outcomes and prohibiting us from of really having this 360 patient view that we've been talking about. And maybe to add to Scott's, right, if we really believe that software can heal the world, how do these two subjects marry, right? Like, what is the role that like software will play in addressing the biggest barriers that you see today?
That's a great question. So I'm at Rush University Medical Center. We're in Chicago. For those not familiar with Chicago, it's a huge income disparity, highly segregated. And we took a stand 5 years ago, making the life expectancy gap part of our mission. So zip codes a couple of blocks away, you'll see a 30-year life expectancy gap between the poorest zip codes and the most wealthy zip codes that's just a mile away. And I think that's a big mission. And a lot of people that join our institution want to work for big missions. And when we think about tech, we try to think about how can that inform our ability to be part of that mission to close the life expectancy gap. One example we've done is, obviously, like many academic institutions, produce a lot of academic research. We partnered with one of the Silicon startup companies to be able to work with our Medicaid population. And the reason why we did that was because we saw across our different populations, the Medicaid population, higher hypertension rates, higher ED utilization, higher 30-day admissions, KPIs that we track on a regular basis. And we wanted to be able to make sure there was tech that's focused on understanding why those gaps exist and how do we close it. And so we were able to combine our research with expertise around behavior change and apply a reward setting to be able to address the social determinants of health within those communities. And not only were we able to get more engagement in folks that in drivers that help reduce hypertension, but we were also able to identify gaps in the community. So you have people that are active, but they can't walk outside. Why can't they walk outside? Because there's violence outside. There's not a built neighborhood outside. They want to get good food, and they have rewards to get food, but they have to travel miles to go to a grocery store. This not only informs how we engage our patients, but it also informs how we think about community investment, how we partner in terms of employing individuals proximal to the community. It has outsized impact beyond just the traditional metrics that we are identifying in the healthcare setting. So I think partnership is a huge deal because you have to be able to understand the DNA of the community, and you have to be able to understand why institutions and folks that join institutions join them. And that's what we've been able to do in terms of partnering with tech and software. And I think software will be able to drive that, catalyze that. And in the future, if we're thinking 5, 10 years from now, it'll be a arrangement where physicians can talk to their patients and have a level of community again, and be in the background, like instead of a situation where we are currently in, physician burnout and physicians feeling inundated with clicks and unsure if this is what they signed up for.
For sure. And I think that connects pretty well to what Krish was talking about, having deep empathy, not only for the patients, but also for the providers, right? So I guess question to you, Krish, like how can, and also going back a little bit to what we were talking about, patient activation and engagement, how do you believe that health systems can rethink their approach to engagement to drive better adherence and outcomes? And building on what Dr. Walker was speaking, what role do you think that public-private partnerships can play in addressing some of these SDOH challenges?
I'll try to be succinct, and I'd also invite my colleagues to add here. The way to think about it is patients consume information not just in a clinical setting, right? It happens in communities they live in, and there are a significant number of other resources they leverage, family members, etc. And so if you sort of follow this the school of thought around principles of influence, right? There is a way to influence patient which comes from a place of authority, which is I am a heart specialist and I can tell you from a place of deep expertise in heart disease, and that comes from a place of authority. There is also a place of influence, which is I have a friend who has had a shared experience, who's lived through exactly that, and he or she is able to tell me as to what they went through and how they managed to overcome their condition. And so ultimately, the ability to be able to meet the patient in the setting where they consume that information is a critical element of patient activation. Now, for people that struggle with access, and that could be for whatever reason, right, that they have that barrier to access. It may be because of, any number of issues such as social, socioeconomic, where they live, and so on and so forth. Uh, there are a series of governmental and non-governmental organizations that deliver services that are material to activating a patient and engaging a patient, and ultimately delivering all that is required to deliver care. And facetiously, what I'd say is it's not just a pill, it's not just a procedure, it's everything associated with the ability for that patient to be able to consume that care. It could be transportation, could be nutrition, it could be any other kind of assistance, right? And so great healthcare organizations and organizations that enable them, technology in this particular case being one of the major contributors, I think would do well when they recognize, integrate, and engage all of these touch points such that there's visibility and collaboration between what the patient needs and what each one of these touch points are able to deliver to them, right? Now, with regards to empathy, to put it very simply, it is being really passionate about user experience, right? I think we've had one too many provider portals, one too many patient portals, et cetera, somehow expecting that that is the place where the physician is going to spend their entire life, or that's where the patient is going to spend their entire life, right? So the ability to be able to recognize what the provider does before, during, and after their engagement with a patient, and then being able to deliver the information succinctly in workflow, I think is a very, very critical part of it. So when I talk about empathy, it's really about know what is the best place for you to be able to be helpful, right, to the user in question here, rather than saying, I've got the most comprehensive information. It is of no use unless that information is consumed and put to use.
Christian, maybe going back, 15 seconds. I really like the way that you kind of framed, we need to sometimes disconnect the provider from the healthcare system, because I think that sometimes we tend to assume that the provider is at fault, right? That healthcare bias exists with the provider. And I'm thinking, right, something like Dr. Walker being in an ER environment where providers themselves are lacking the time, data, or tools to fully understand that patient social and economic barriers to care. Well, the responsibility does fall on them, but then the system is not enabling them to actually see that full patient 360. Right? So if we actually shift a little bit of that responsibility to the system, and this is maybe a question best suited for you, Dr. Walker, how do you think that the healthcare systems can actually better integrate training, workflow support, and technology to actually ensure that those providers, when they're moving really fast, have the right tools to make these informed, equitable decisions without adding to their workload?
Yeah, that's a great question, because what you asked is inherent bias that a physician may experience, and then things that just may be intended or unintended from the system that they may be working in. And I think I always start with research, because I grew up in academia, and my natural inclination is when you see a healthcare disparity, all it is a gap. All it is that you're observing differences. So if you're looking at heart disease rates, if you're looking at trauma rates, all you're looking at is difference, whether it be by age, sex, race, gender. And then the next step really to do is just ask the question, why is there a gap? And the gaps and the drivers to those gaps can be a multitude of issues. But we have decades and decades of research that have evaluated when bias exists, what are some of those drivers. Obviously, unemployment can be a driver for certain for certain diseases and risks, but you have to be able to kind of just have it front and center or in the back of your mind. What the system could do is a little bit different. Sometimes it is bothering the physician and highlighting different biases or trends that may be occurring in the system that may be unintended, and they want to be able to address it from a macro level. From the physician standpoint, part of it is when you're going through medical school training, you're just learning about what may be the biases that may exist from just how you grew up and just how that may inform your clinical decision making. And that's important. When it comes to software and how software can help support that, for example, in our value-based care setting, we do primary care report cards. We provide KPI evaluations for all our providers. And then we do a sit down with them separately just to talk through what may be some of the issues or highlight areas of opportunity. So it takes a little bit of both. It takes a little bit of software and it takes a little bit of leadership to be able to find that time to work with your team to understand if bias exists and how you're able to address it. But I think the other component, and if we're talking historically wise, we have to be able to stay on top of different types of policy trends that may lead to widened disparities. In Chicago, real estate and the ability to be on a wealth path, particularly for an African-American community, wasn't as accessible as others. So being able to understand how that influences the health of a community is very important. And when we're talking about a life expectancy gap or big missions that help provide how we set the direction straight, being cognizant of that is important because it helps us address what type of programs that we need to be able to fill that gap, whether it's food insecurity gaps, whether it's housing, or whatever it may be, to be able to make sure that people don't have those barriers over influencing their ability to remain healthy or become healthy.
Makes total sense. Wanted to pause here for a second. First of all, to encourage our audience to please submit questions in our Q&A for our panelists, like very much meant to be an open discussion that keeps evolving. And with that being said, I actually have one question here for the panelists. Come from Brow and Spira. She asks, do you think the recent government approach towards DEI will impact the equity and access initiatives within CMMI and HHS?
I probably touch DC a lot for us, and Garth, happy to let you follow. I'll just, look, it's very early in this next administration, and I'm not going to comment on the politics of some of their initiatives. I think it's fair to say we're in a new time of uncertainty, and government, which may be a surprise to some, is by far the largest purchaser of healthcare in America. And to a previous answer, like, our system is not very efficient, it's not very equitable, and it's not very high quality for what we spend. So no one can doubt that, some significant change is needed. And change can be really positive. It can also be really disruptive. It can lead to expected, long-term progress. It can also lead to unexpected outcomes. So I think my short answer is we're just going to have to see. I'll add, though, that amidst the uncertainty, in my experience, that uncertainty breeds opportunity. And those times of opportunity, it turns out, are usually a pretty good time for founders, like particularly founders who have a capability, have an energy, but also have a view to a market where they think they can make a difference. So I think the next 4 to 8 years are going to be an amazing time of this next epic of software and AI founders taking really ambitious shots. They can radically change quality, cost, and outcomes. But I think it's going to be a tempestuous time. Particularly, I don't think it's a good time to build a company that just sits at the trough of public spend in areas that are inefficient. But that's not really the business that Insight's in anyway. We're in the business of founders that get an edge amidst the uncertainty into something that matters.
I could follow up there. I would say that from a DEI perspective, and I think when I listen to a lot of DEI leaders across the nation, it's definitely a challenging time. But I think our institution sees it as an area of opportunity. I think we 5 years ago, we made the commitment to integrating health equity into our health system strategy, and it wasn't political. It was more around just what is the data informing us, and how do we make sure that we keep our communities healthy. And one of the best statements that I remember from the White House was that good policy comes from great data and empathy. And when you leverage the data and you juxtapose it with what people and individuals are going through, especially something as sacred as their health, being committed to the research around health equity and DEI builds trust. And we need people to be able to trust our institutions and trust that we are doing the exercise of trying to make sure that we keep them healthy. And I think that it's still very early because, I know every institution is working hard to examine what all these executive orders mean. But I think the mission still remains the same in terms of how we think about health equity and making sure that everybody gets optimal health regardless of where they're from.
Garth, I want to write this down. I want to make sure I quote you the right way. The first words I wrote down were data plus empathy. I kind of feel like the quotation I got was basically data plus empathy leads us as an institution to the right action. Is that about what you said? I want you to say it or improve that.
Absolutely. I said good policy is a combination of data and empathy. And I think for our leaders, that's what we're seeking for. And I think that's what people are seeking for. Nobody will pursue a healthcare institution or a tech if they don't trust the institution or trust who's behind it. And by doing the exercise of describing your data, looking into your data, and putting forth the appropriate level of empathy, builds that trust for people to engage your health system and engage the data and the tech that you're delivering.
You know, if I could jump in for a second, that is just so profoundly well said, Garth. And this is not an advertisement. It's that we realize this is inside employees. We have this very, very special sourcing engine, which being in venture capital can sound glorious, but it is hard work, just trying to find the right founders, working on the right thing. And on the other hand, also on this calls, we have a lot of our portfolio companies, and I will deserve the comments of how did you forget to mention us? But if I could just quickly go across, I'm gonna repeat what you said. What we take from a policy perspective is if you look at the data plus empathy, it leads us to the right action. I'm led to think about, and I'm skipping around off the top of my mind, Forta is an insight company that is full stack autism care, where the initial data before the company was started, it was, why are 38% of families not getting any autism treatment? It started with a question, it started with data, and it said, is there something you can empathetically build for them? Again, with the shortage of clinical providers and the failures of certain services businesses in that sector. It's like, okay, well, is there an AI software driven version? And by the way, it came centered to like, well, how do you support the family to do that? A different one, you know, one of our flagship companies in Dallas called Lantern is a two-sided bundled marketplace. Like, what does that mean? It just systemically tries to work with employers and now increasingly plans facing the moral imperative, we just can't pass all these healthcare costs on to our employees. And it turns around and says, well, for all the expensive stuff that you know is coming down the pike, is there a way to just lay hands on that family, if you will, but use software to optimize where is there the highest quality provider who's willing to provide this service at a below average cost? And that just creates this reinforcing flywheel of higher quality, which is kind of like anti-oligopolistic, because one of the big problems of the very expensive systems, we have no regard to quality. We have a moonshot out of Madrid, which is asking, hey, by API, what if we could read any EKG from anywhere in the world in seconds, not hours and days, across 117 cardiovascular diseases? We are making, you know, CE and FDA claims, but we're probably 2 years away before that breadth is available and an API. But I just think about all the times in every community when we don't execute on an EKG. We have things like in mental health, like Alma, which is all about a network to extend and destigmatize mental health, but aligned to your insurance and your coverage, including Medicaid, wherever you are. Or we have deep tech shots in mental health like Kintsugi, which is regardless of your race, nationality, and even language, if we can capture 20 to 40 seconds of voice, we have a read of your mental health condition higher in quality and specificity than a PHQ-9. Honestly, there's like 5 or 6 more. Chris already alluded to like the mission of APRIS, which partially became Bamboo, which is this layer of network and intelligence that this country, when people are in this moment of crisis. And I haven't even hit on the areas where we're driving algorithmic improvement without bias, areas where we're getting assisting aging in families as their loved one, like things like Sensi in the home and Water Lily, that's AI planning for every type of middle-class family. It's kind of a long list, and I'm trying to connect for everyone. I'm a little bit speaking to the portfolio companies who have joined today. Like the thing you are working hard on every day actually connects directly back to what Garth just said. It's data and empathy. In his case, leads to policy, right? He helps run one of the most important healthcare providers in the country. But I think that exact same language can be an inspiration to our use cases where we're trying to use software and empathy to unlock these use cases for patients. And I know I missed some good portfolio companies and I deserve to be yelled at later, but I'm glad we got a couple of those on the table.
No, but it also raises that it's also a selfish interest, right? You want to make sure that you're moving in the right direction in the interest of the people that either work with you, work for you, and that you're delivering care to on a regular basis. And I think we don't want to get away from the notion that the most important piece to all of this is people. And I think being able to be reminded of that on a regular basis is what's going to drive the ingenuity and the innovation and the efficacy that's being seen across the portfolio companies that Insight's leading, as well as across the nation.
I love this. And maybe to continue kind of pulling this thread of data plus empathy. Scott, I've heard you before saying that we need more founders that reflect the United States population, right? Because they are the ones that can, first and foremost, empathize with the problems that their own communities face. Right? So how can investors like better support driving diverse founders in health tech?
I just want to illuminate the point you made. For example, we're hoping to have a term sheet accepted in the next 24 hours. And among the things we like about the company, and it does actually create a more fair and equitable world, this company, but I can't talk about it because it's not signed. But I will tell you that within our materials, it's like we have perfect founder market fit, meaning this founder, even if there's 17 other competitors, he was the best placed at that moment spinning out of a certain company. Like he's made the best product that was the best software and AI driven because he understood the problem the best. And so I now want to connect this back to, I'm going to connect it back to a previous example. We're not going to build empathetic software and empathy-driven primary care in rural Kansas from someone sitting randomly in New York City or San Francisco. And similarly, we're not going to build a next version of real-world data meets SDOH or profitable software-driven primary care in an urban Houston environment from someone sitting in Verona, Wisconsin. Like, we really want to find founders grounded and both anthropologically kind of grounded in the problem and also closer to the bare metal of how you create the right solution. There's a fair amount of data that in digital health, which I view as yesterday's epic, and it's a word for incrementalism. Like we want this future of computational care that is much more exponential, much more optimistic, but also solving really hard things. And we deeply suspect it's going to come from founders who originate from like the community for which they're solving. So I don't think we're going to create better, delightful, magical, higher quality healthcare solutions just in 1 or 2 neighborhoods. I think it's going to come from founders that we're going to find who are working on the problem, kind of emanating from the community. So I think there's going to be a next wave of Chicago-based founders, for example, people who have did in residency with Garth, or had interactions with top quality institutions, but then step away and say, well, what's another version of how I can build augmentative software that makes this world with higher quality and low cost? Bella, I think your question to me was, well, what can we do to facilitate that? First, I want to honor what we do, and I want to make another offer. One thing is that, our sourcing engine is colorblind. That engine is after founders on the problem. So we're doing everything we can to uncover those founders. On the other hand, there's kind of a clarion call here where we need more African-American founders working in the place for their community. We need more founders of all their communities working on the problem. I will say, to the degree that venture capital can be accused of being clubby or insular, there's little things we can do. I'll just speak for myself. I'll answer any LinkedIn request from a founder who can just demonstrate, I'm working on this problem. Can I show you what I'm working on? Now, I only do healthcare, so I'm not trying to be all things to all people, but any founder from any background, you don't just have to get to one of our CEOs or get to another partner that respects me. I'm open and available and spend a fair amount of time, because I think it's very important we have that aperture open, that we don't just have privileged gates that prevent that access.
Well said.
Well, I think that's a great point. I think it tacks onto a lot of the challenges that occur. We have a university as well, and when we think about research and research innovation, part of it is recruiting talent that is most likely to pursue a problem that we see in our community. And I think, for example, when I think about sickle cell disease, a lot of the top researchers who pursued that had an experience with it. And so you have to be able to think about pathways that are being able to pursue and nurture, and that's fertile for individuals to be successful and be able to contribute to the innovation pipeline. So now you have a host of research. I'm picking on sickle cell because it affects African American communities more than others. But now you have a host of potential of different types of innovation that could be scaled based off of the innovation that's produced from research. So I think these complex problems, when they're neglected, end up becoming center. And then we have to figure out how to be able to solve that solution, or be prepared how to solve that solution if that exists.
And I guess one more question from my end on the topic around investing in inclusive innovation. Krish, as the former CEO of Bamboo Health, which in my personal belief is kind of the epitome of a company that has been able to effectively integrate social and clinical factors into their business model, what do you believe are the models that have the most potential to scale health equity solutions sustainably?
Yeah, I think the ones that distinguish themselves when I think about successful startups in this area, they are ones that have a deep amount of humility and understand the magnitude and complexity of the problem. So my sort of first dead giveaway with regards to red flag is when a founder or the founding team talks about having found a silver bullet to address this problem. Candidly, there are no silver bullets. The companies that I really admire are ones that are very, very honest with themselves about the true impact of their technology. And they are rigorous students of the user experience and very, very closely tie their R&D teams to their customer-facing teams, so they know exactly where their products are getting used and where their products excel and where they are challenged. In other words, they have this constant feedback loop straight from the field that improves the products. And candidly, one other dead giveaway for me with regards to whether they are trending towards success or not is also what I'd call as the diversity of thought and experiences they have among their employees. This is a lot of what Scott was talking about, which is, do they really get what their users are saying, what the users are living through, the experiences they're sharing, et cetera. And so again, you can talk about it in healthcare, you could talk about it in the context of health equity, or you could talk about it in terms of just good software development, which is be maniacal about your users and the user experience, and be humble about not having found a silver bullet to it, and constantly keep reinforcing your product with the feedback you're getting from the users, whom ultimately you're serving. Seems
Super well
like motherhood
said.
and apple pie, but it's really back to basics, I think.
I call that the intellectual athlete, somebody who is constantly questioning, or constantly pushing themselves towards the goalpost. I agree.
I'm gonna steal that one, Dr. Walker. With that, I just saw the time. It seems we only have 5 minutes, which is truly sad because I could go for hours here, and I very much mean that. Maybe in the interest of time, would just love to hear any closing thoughts from the panelists, and kind of, in that vein, if any of you, have top of mind any transformational trends that you believe will really impact health equity moving forward, I'd love to hear those. Maybe Dr. Walker, you can go
Yeah.
first.
Thank you. I can go first. Well, thank you, Insight, for giving me the opportunity to spend some time with you. It's an honor. You guys are doing incredible work at the forefront of healthcare. I would say that in terms of trends that we just need to be aware of, obviously I'm in the value-based care space, but I would say trends that are helping inform that outsized impact that we were talking about. The technology complements the physician well, integrates into the workflow well, but also provides lenses in terms of where there's limitations of how we can address some of those social and economic barriers. And I brought up the example earlier, but we can't get patients and communities to be healthier if we're not able to have a 360 picture of not just themselves, but also the communities that they reside. And I think technology that's able to provide a better picture and a better lens to that will have outsized impact on communities and the ability for physicians to deliver great care. I'll hot potato it to Chris.
Yeah, listen, I think compute cycles are definitely getting, more and more accessible. It's not about just whether they are cheap or not. I think about it as, this whole concept of being able to take so many different factors to create, software, create care plans, create interventions for that patient of one that I was talking about earlier, is one where the tooling for creating intelligent models and factoring in feedback to refine the products continuously, I think that is improving literally by the day. And so I think it behooves entrepreneurs and technology leaders to pay a lot of attention to these emerging AI technologies and use them in how they shape that dialogue that is happening between patient and physician to ultimately activate the patient and improve outcomes.
I generally find that historical change, if you actually look in that moment, it's very, very different than the humans who were present just before that moment assumed that the future would play out. We know we're in a broken system in healthcare. Like, this is probably the country I want to be in if I have a very complex form of cancer. But across the society, if I were trying to take care of 100,000 people, it turns out we're the least developed industrialized nation and the most expensive. But change is coming. And there are some parts of how we do healthcare that are very sclerotic. Like, they're just not going to change overnight. They're going to change very, very slowly. There are other parts that may kind of whipsaw depending on the political winds and certain mechanisms of funding. But we're on the forefront of technological change, which, by the way, done poorly can do harm. So there's a real responsibility. And I'm going to make a comment. This would be clear, like, not everything should be capitalistic. Not everything that's capitalistic should be venture backed. I'm not in love that, everything should look attractive to a VC bro. That is not what I'm saying. But I'm absolutely convinced that capitalism is an appropriate allocation of society's resources and certain constraints when it's properly understood by government. And I'll go further to say catalytic venture within capitalism can be something that truly creates an exponential future beyond what most people could have thought even 5 or 10 years before. So while those who spend a little too much time with me know how much we hit our foreheads against the brick wall of oligopoly, like there is palpable real change coming. I don't know of any that I think are really significant that don't have kind of a clinical and entrepreneurial spirit combined with software. So my point is, I'm not just seeing it from the songbook. The only software will solve things. Of course not. We have political problems. We have polarization problems. We have lots of problems I'm not going to be able to solve. But it's a degree that each of us are lucky to work on things hopefully greater than ourselves. I cannot emphasize enough. You cannot limit what's possible from the right couple of founders using software and compute and a view towards how you raise clinical quality. I cannot emphasize enough how much is possible in the next 10 to 15 years. So one, health equity is not like, oh, let's not talk about capitalism, let's talk about health equity. I'm like, no. If you would just actually evaluate our 330 to 350 million people in this country and all the ways we run short, and then you start to think about how founders could power next things. We are in a, whether you are at a portfolio company, whether to Krish's language, you are in product at one of these companies, or whether you're at Insight and trying to figure out, where you prioritize what's on your dash of pursuing, next companies. Like, the opportunity in this space is profound, and it has this unique halo of if we get it right, it's probably really, really good for the world we hand to our grandchildren. But it's also this catalytic capitalism is the right container to pursue it. And I just kind of feel lucky we get to do that each day. With that, I apologize to use too many words. And Garth, I just want to thank you again for being here.
Well,
Thank you, Garth. Yeah.
Thank you for having me.
Echo that sentiment. Thank you so much, Dr. Walker, and thank you everyone that attended today. Hopefully the first of many fruitful discussions here. And as always, you can reach out if there are any questions directly to the team.
Thank you.
Thanks, everybody.
Thanks,
Thank
everyone.
you, Isabella, for moderating, and we appreciate everyone joining. So with that, have a good afternoon.